So it's a real pleasure to have Dr. Sam Chang, who is professor of urologic oncology at Vanderbilt. And again, welcome to Bladder Cancer Academy. And the whole community sincerely appreciates all your efforts with guidelines that were recently presented by AUA. So there's two sets of guidelines.
Right.
One was the non-muscle invasive disease and then muscle invasive disease. So, I enjoyed your presentation. There were like 40 bullet points.
Yeah,
so,
So
and
that's the condensed version. That's the condensed version. That's right. That's right.
And you went through that eloquently.
Right.
So if you were to take, for the urology community,
yes,
what would you say are maybe those guidelines that you think may be under-recognized and those that we should emphasize for the practicing urology community?
Yeah, I think that for me, it's a combination of let's focus on both the lower risk and the higher risk patients. And for the lower risk, we need to be doing less.
Right.
And that means less surveillance cystoscopies, less X-ray imaging, less exposure to radiation, less costly urine tests, all those types of things. But then for the higher risk patients, the T1 tumors, those patients that have CIS or recurrent disease, those patients we need to keep an eye on being aggressive, trying to prevent progression, and being timely with cystectomy. So for those patients, the importance of maintenance BCG, a more rigorous surveillance evaluation, and understanding that cystectomy should be considered early as opposed to at a too late time period.
So let's take the patient, smoker. Hopefully you've convinced them to a smoking
Excellent
cessation.
Point there too,
right?
Absolutely.
I mean, because it still has some downstream advantages as far as their well-being. But let's take you have a 1 centimeter single superficial papillary tumor. So how would you follow that patient in terms of surveillance,
Great point.
and imaging, if at all?
So that patient, it's important, has to have an initial resection biopsy removal. We need that for evaluation and to make sure that our gut feeling that this is a low risk, low grade tumor. So once we have that, then we advocate a 3-month evaluation. And that's an in-office cystoscopy, not with a urine cytology, not with an upper tract imaging, but an evaluation in the office. And if that evaluation in the office looks good, there's no evidence of residual tumor, then at that point, as opposed to doing another urine test at 3 months, another cystoscopy at 3 months, no, we advocate basically 6 to 9 months later, basically at near the 1-year mark, to do an evaluation there, and then after that, actually decrease the number of cystoscopies after that.
So you may be doing a cystoscopy annually instead of every.
Correct.
And again,
absolutely.
So should you do an initial imaging of the upper tract, or is that?
We allow that.
Okay.
We allow that, and that's specifically kind of the phrasing that we use, as opposed to mandating it or as opposed to refusing it. And that's to allow the clinician, hey, I want to make sure maybe it's close to the urethral orifice, or maybe I want to make sure that there's nothing on the other side, upper tract, all those types of things. So we allow it, but it's not something we say that needs to be done. And in fact, we discourage the routine surveillance upper tract imaging.
So let's take the high-risk patient. So you have a 2 centimeter bladder tumor, you resect it, and you're absolutely convinced that you've done a complete resection. There's muscle that is identified in the surgical specimen, and it's high grade, it's into the lamina propria. So there's a lot of discussion about re-resection. You're convinced, you're a seasoned resectionist.
Yes.
Do you need to go back and re-resect that?
And that's a point that is discussed oftentimes, and what I tell folks is that this is not a time to feel too good about yourself.
It's not ego, right?
Exactly.
Even the best of the best.
Even or experience, as you say, is the understanding that the microscopic evaluation of the disease far exceeds our visual interpretation of I think I've gotten it all. And for the benefit of the patient, if you are planning on saving this person's bladder with intravesical therapies afterwards, repeat TURBTs, then I think it is to the patient's best benefit to evaluate further with a repeat resection. Your point regarding a smaller tumor, an experienced resectionist, absolutely, I think probably adequate, but are you sure? No. Does that secondary repeat TUR give you more evidence regarding staging, a better profile regarding prognosis of impact or treatment afterwards? Absolutely. And importantly, if you do a repeat resection and there is no residual disease, the likelihood of success with intravesical therapy is actually increased. And so for all those reasons, I myself advocate strongly. And even for those patients that don't have lamina propria involvement, just TA, if there's extensive disease or I'm not convinced that all the tumors are resected, I advocate a repeat resection at that point as well.
So high-risk T1 disease, how often, if you look at its natural history, assume it's treated according to guidelines, will you actually get muscle-invasive disease and go on to cystectomy?
Great point. If you do a repeat resection without any intravesical therapy and you're still T1 and you give intravesical therapy, your chance of cure is 60, 70, 80%, much like CIS and TA disease. However, if you have intravesical treatment and you have persistent T1 disease, your chance of muscle progression and advanced disease is greater than 50%, probably up to 80%. And so for those patients that have persistent T1 disease, your chance of progression is very, very high. And I tell folks, and this is also included in the guidelines, is in those patients we thought were T1 despite treatments and resections and had their bladders removed for T1 only disease, 15 to 20% positive nodal rate. So we're talking about a pretty aggressive disease process.
So there is a difference between persistence versus recurrence
No question.
So, why did we have this BCG shortage? Was it they just weren't? Was it an economic?
I think it was a combination of increased demand, understanding that BCG maintenance was starting to take off, decreased competitors, lack of compensation to the companies, and then it's not the easiest necessarily to make and have quality standards. And so as a result, as a company, I'm not making a large profit. This is not necessarily in my area of future kind of goal-oriented success, and so as a result, it just started fading.
Well, you sort of went, the EpiPen, they were charging thousands of dollars, right? So the government sort of pushed them to come down.
Yeah.
I wonder maybe the real need is they have to make it economically viable for the industry.
Oh, I think there's going to have to be something done, and fortunately the patient advocacy groups, the AUA, the SUO have really, I think, worked vigorously to try to support increased not only understanding of the importance of this medication, but try to persuade the government that, hey, look, we need to do something about making sure that we maintain the standards, yes, but also maintain these companies in terms of the production.
So I got to make sure I get you back for your next presentation, which
great.
will be on
this is the
muscle-invasive disease. So
That's
what's going to
exactly.
be the take-home message for that presentation?
I think Neil really emphasized for the very important aspect of understanding that, taking care of urologic cancers is not just the role of the radiation doctor or the urologic surgeon or the oncologist. It's really incorporating everybody in a multidisciplinary approach. And that is actually, I think, one of the key aspects of the muscle-invasive guidelines.
So is there going to be a role for radiation
Unquestionably.
oncology? Because for the most part, they were giving it as neoadjuvant. That sort of fell off. I guess the issue of possibly bladder sparing with radiation.
Yep.
But you think in that sort of multidisciplinary sort of future, it really is going to take oncology, urology, and radiation oncology to maximize management of the disease?
I do, and I think we owe that to the patients to understand that these are possible therapeutic interventions, and that in certain instances that a combination of non-surgical removal of the bladder may be just as successful as cystectomy, and understanding the role and the interaction of, I think, all the disciplines will be really important.
So again, Bladder Cancer Academy, I think one of the reasons it's been very successful is we've been able to attract luminaries like yourself on the faculty. So one, we appreciate your participation in Bladder Cancer Academy, and also to echo Neil's comments is, again, thanking you for your tremendous contributions to the field.
Great, thanks very much.